Enda King, welcome back to the Pacey Performance Podcast. It's been far too long.
Rob Pacey, a pleasure as always. Thank you very much for the invitation.
I was actually looking back at the dates that you and I first connected and had you on the podcast and things, and gingers aren't supposed to go grey, but I'm definitely a lot greyer than I was 8 years ago whenever we first spoke. So I appreciate you coming back.
You're carrying it better than I'm carrying it anyway, that's for sure.
Thank you. But no, thank you for coming back on. Bit of a theme of these last few weeks with people coming on the podcast because you're all coming to LA to speak at the Sportsman Return to Play conference on the 27th, 29th of June. I'll be smothered in Factor 50 at that point on the West Coast, no doubt. But would you be give us a summary of what you're going to chat about over there? Firstly, I'm super excited to have you and the bunch of people that we've got. Just give people a bit of an insight.
Yeah, to be honest with you, I'm more excited to go and listen to who else is going to be presenting as much as I am presenting myself. But I'll be looking at athletic hip and groin. It's an area that I have a long-standing interest in, both clinically and from a research point of view. I'll be trying to share or help the attendees get some clarity around, differential diagnosis. Does it matter? How do you make it? How accurate can we be? And we might even chat about some of those things in a little bit. And then from a rehabilitation point of view, in part A, kind of how do you break an athlete down to build them back up again? What are the key... You see what you look for and you look for what you know. So what are the key things to try and look for as you go along? And then share some exercise ideas, etc., while acknowledging there's a million ways of doing it. What's more important is, are you affecting change, and how is your reloading strategy evolving over that time? And hopefully people will have something to reflect their own practice against and take some content from it.
Amazing. And for the first time, I think this is our 5th conference, we're actually doing a pre-conference, which you're leading on the Friday night. So I've had a few questions about that because we haven't done it before. So 6 till 8 on the Friday the 27th, you'll do a pre-conference workshop. Same location, same cool location, but just the pre-conference.
No, and looking forward, because it's interesting, we're having this discussion today at work, in that you can talk about any injury until you're blue in the face, but ultimately it's the practical element of it and seeing what you think you see and how things evolve over time. So the practical workshop will be, I hope it'll be worthwhile.
Yeah, I'm sure it will. Right, let's dive in. Before we do that, brief bio for you. In terms of job title and where you were, I think your last time you were still in Ireland. I don't think you were.
I was, yeah.
Yeah, that's right. Give us not people need an update, but give us a bit of an update.
Yes, so I'm enjoying the late spring here in Doha. The weather, I was back home in Ireland last week. The weather is definitely a couple of degrees warmer here in Doha. I'm 3 years here now in Aspetar as head of elite performance and development. Very exciting place to work, very, very dynamic, lots of change and lots of exciting projects coming forward, which we'll talk about in the future. But my role is primarily working with the team that we have, trying to evolve our clinical pathways, get consistency across the group, and then evolve that consistency going forward in terms of the expertise within the group and doing further research to evolve our practice, and then working on our systems, our pathways, our facilities, to make sure that we can offer the best care to both the local athletes but also the international athletes that come and spend time with us, and then still maintaining some clinical caseload, primarily with international athletes across sports, predominantly lower limb, whether that's ACL, hip and groin, soft tissue, usually recurrent calf, hamstring and rec fem injuries. So it's a balancing act between the two. Very dynamic team, lots happening, and so some hopefully exciting stuff going forward.
Do you have more externals come in these days than you ever have done, or has it always been? Yeah. It's
a momentum. I suppose I'm quite lucky that I came to Doha at a time when it was on the upward curve again. Like, obviously COVID killed a lot of travel. There'd been an evolution of every institution over time, but certainly it's steady and rising all the time, and that's partly to do with the refurbishment of the facilities and the new development that we have. It's partly to do with the excellent staff we have and the evolution of that coming forward. And I think a good marker for us is always like every one international athlete should lead to two more. So, you know, that player very commonly now is looking to come back for pre-season when they have time off, A, for the warm weather, and B, for a review of where they're at in progression. They'll tell a teammate, or the club will have another player where they're happy to collaborate with them and have that mutual trust that, look, we're looking to support the team as best we can and look after their athlete when we're given the privilege. So there definitely seems to be a strong momentum for it, and long may it continue.
Amazing. Right, let's dive in. So some of the stuff will cross over into what you're going to chat about in LA, but there'll be some obviously stuff that won't as well. A simple one, but a complex one. Why do athletes get hip and groin pain?
I suppose when an athlete does present with hip and groin pain, very often it's the straw that has broken the camel's back. You do have acute episodes, mostly around musculotendinous injuries of primarily the adductor longus, but maybe iliopsoas and rec fem as well. But when we're looking at more, I suppose, the chronic presentations of overload of the pubic bone, the adjacent musculotendinous structures, or the hip joint, it's always a combination of three things. Number one is load. You know, you don't really get athletic groin pain sitting watching Netflix. So there's a loading or a change in load component to it. Number two is your biomechanics. So the way that you move will influence where that load goes. It's not good or bad. It influences where that area is preferentially loaded. And number three then is your anatomy. Perhaps you have a history of groin pain, therefore your tissues are a little bit more sensitive. You might have a large cam morphology, which means your room for error, or the freedom you have before you impinge the joint and send that stress across the superior pubic ramus, might be different than someone who doesn't have a cam lesion for the same amount of load and for the same movement strategies. So I think when we're looking to intervene, you're always looking at what's the anatomy like, what's the load like, and then what's the movement like, and then how do those combinations, that triangle, influence when they ultimately present with symptoms.
And why is that so difficult to understand which point of the triangle to gravitate towards to try to understand why this is happening?
I think it's because it's so variable. So if someone presents with you with, let's say, pubic bone edema, I don't really know what their anatomy is like until I go and examine it. Another player could have the same loading strategy and have had no issues. And everyone moves a little bit differently, has a different injury history, etc. So I think part of it is the diagnosis bit is difficult because what's very clear now is that our tests are very sensitive, but they're not very specific. So if you squeeze your knees together and you have pain, I don't really know specifically where your pain is coming from. If you've no pain, there's a good chance you don't have an adductor problem and you don't have a pubic problem. So they're good clearance tests, but they're not very specific diagnostic tests. Similarly, when it comes to radiology, as we're increasingly seeing, like we saw on the low back and like we saw on the shoulder previously, there's a lot of false positives. So in healthy athletes, especially those playing change direction sports, cam morphology is very, very common. Labral tears are very, very common. Pubic bone edema is very common, in spite of the fact that they're all symptom-free. So if you go looking for stuff on radiology, you'll find it. Whether it's relevant or not to that presentation is very difficult. And then palpation, in terms of if I put my finger on my pubic tubercle, there's a number of structures that you're touching there at any given point in time. So you're looking to try and build that picture by where does the pain being brought on, what does the radiology say, and what are your palpation skills. But any one of those alone, it makes it very difficult to have a diagnosis. Therefore, we all start calling it different things. We start giving different strategies. And at least half of these athletes will have pain in multiple different areas at the same time. So do I give you your pubic program or your adductor program or your inguinal program off the back of that? So it's a mixed bag, which makes being clear where the pain is coming from difficult, and therefore when you're not clear where the pain is coming from, you get variety of management strategies, and that's where certainly a lot of the inconsistency or stress is caused from.
So to get clear on where that pain is actually coming from, what's your recommendations?
I think you really can't be deliberately specific unless you can reproduce their pain, unless you can palpate or touch that pain and put your finger on it, and then relate that back to the radiological findings. And I've seen people make diagnosis off scans or ultrasounds alone, which I think is madness. I've made people put their finger on, I've seen them put their finger on and say, well, that's definitely a pubic bone edema, that's definitely an adductor issue, or squeeze their knees together and say that's definitely a adductor problem because you've pain on a squeeze test. And I think it's a fallacy to fall onto one specific component and not put the three of them together. You don't need all three because, ironically, for the purpose of the diagnosis, what are we looking for? We're looking to say it's not a medical issue. It's something that is non-medical. And then your thing is, well, is it for rehab or is it for something else? So if you call it pubic pain, Rob, and I call it adductor pain, if we both decide rehab is the way forward, it doesn't really matter if it's different in what we call it. So I think when you're making that diagnosis, what you want to be is not missing something that needs a medical referral, and after that then deciding, is it for something that's for rehab or is it something that requires a different intervention.
So what would trigger a medical referral? What kind of symptoms? What you're seeing?
I think when you're, if you look at, say, it's a lot of young males that tends to get this, but like you're looking for inflammatory conditions, something that might be masking as an inflammatory disease or ankylosing spondylitis or something like that. In both male and female, there's a number of either gynecological or other low abdominal medical conditions that can give referrals to the area. Very often these symptoms tend to be non-mechanical. They tend to have a slightly different pattern than you see in your athletic groin pain, which is generally, I load it, it gets sore, I leave it alone, it feels a bit better. They tend to get a different presentations of symptoms that don't necessarily respond as well. So I think you're really just double check, especially the inflammatory disease part, or in your younger athletes, being really careful or cautious about any kind of issues with the epiphyseal plate, especially in the hip joint. I think that's something that warrants a quite urgent orthopedic review. So yeah, you're just looking to check that the big boxes are ticked and that this is something that will do well with more conservative intervention.
I think I may have relayed this story last time. It seems to come to mind that I'm probably boring myself now. I'm repeating stories. But when I worked in football, there was a particular time when there seemed to be so many guys being sent for surgery on groins. It just seemed so regular. What would be the path to surgery when it comes from athletic groin pain?
Yeah, I think the difficulty with athletic groin pain surgery is twofold. Number one is, depending on the surgeon you go to, you'll get quite different procedures for the one athlete presenting with. So one will say this procedure works that. So it makes it difficult then to compare and contrast. Not that it's right or wrong, it's just comparison is difficult. The second thing is that it's often when they've, in inverted commas, failed rehab. But the question is, what does failed rehab mean? Maybe it was just not good rehab on my behalf, and therefore, if someone else had a rehab them, they'd have got better. So I think if you go through the buckets, like certainly there's no reason for surgery for pubic-related groin pain. Like that is a non-runner straight away. And iliopsoas-related groin pain, to be fair. The vast majority has swung away from doing anything for adductor-related groin pain. I can't think of any good reason why you would cut or release anyone's adductors. It's still done in certain areas, but I think thankfully that pendulum is swinging back away from that. And then you come to the inguinal region, which is really where there is either a direct or indirect hernia, or what some would call a posterior wall weakness, that's leading to either irritation of structures in the area. The difficulty with that is there's a huge false positive with that. So if you hypothesize, if you ultrasound an entire Premier League squad, you'll find posterior wall weakness probably in about half of them who've never had groin pain. So the difficulty with that then is it something that could just be reloaded and rehabbed, or is it something that requires specific intervention? So that's definitely a cohort where, and you see it in some where there's a clear frank herniation and there's a clear anatomical disruption, and that may require surgery. The difficulty always with that is the pain coming from that region when you've pain in multiple different areas, and will it settle otherwise? So I'd say the inguinal group is where there's the question mark. For the others, I can't really see a good reason why surgery would be the answer. So
when you mentioned about failed rehabs, what are the main reasons from your experience, and obviously the knowledge that you've got in this particular area and speaking to probably many people who are going through this, what are the reasons for someone failing in rehab and why things don't improve in some individuals and compared to others?
Yeah, so let's assume it's a problem that's suitable for rehab. The pitfalls are that people rehab someone because of where their pain is coming from rather than why they're symptomatic in the area. So simple example might be iliopsoas groin pain or adductor groin pain, and therefore they focus a lot on strengthening those muscles when maybe in fact they're perfectly strong already, but they're overloaded because they're trying to compensate for somewhere else. So getting, narrowly focus on where the pain is coming from rather than why that area is symptomatic. The second thing is probably not being able to identify all of the contributing factors. So an example like this might be, it's not uncommon, let's say post-ankle syndesmosis or some other injury where they start to develop groin pain, not because of the ankle injury, but because of the legacy of the movement strategies that are after that ankle strategy. So for example, I might have had a right ACL or right syndesmosis, have reduced coordination or springiness on that side, and when I'm running, start to work harder on the opposite hip flexor and adductor to compensate for that strategy. So I can treat that local area all I want, but if I'm not addressing the driver or the stance leg as the main factor, I'm going to end up in trouble. And number 3 then is, let's assume I've identified all the contributing factors. My rehab isn't affecting change. So I'm either not picking the right exercises or coaching them the right way or periodizing them and progressing them over time to get change. And, we hold ourselves, let's say an ACL injury, we hold ourselves very accountable to affecting change over time. Whereas in groin pain, it's kind of less so. So really, if you've failed rehab, it can only be that I've addressed all the factors I thought were contributing to the factor and they've continued to have symptoms. But in reality, most of the times where, of course, I've never failed a rehab, but where some are slower than others, it's where I've been missing something. I've been missing 1 or 2 key components. I got too narrow in my assessment, or I assumed the intervention that I was doing was affecting change over time. And that's where your daily and weekly monitoring are really important to make sure your KPI are progressing all the time.
From the practitioners that you've spoken to or practice you've seen, what is the most common reason that it may not fail, but may not be as quick as people want, or I think having to come to you?
I think you can literally split it in 2. It's there's an overloaded structure, let's say the obliques or the rectus abdominis, and they do more core work, even though their core work is bringing on their groin pain because they're continue to overload an area that's overloaded. So I think number 1 is, over focus on strengthening the sore area. That doesn't mean it doesn't need strengthening, but assuming that weakness is the driver of the problem. And then number 2 is not being able to regress your exercises well. So identifying what the problem is, but not being able to regress or manipulate your exercises well enough to find the entry point. The easiest thing is to make them harder. Regressing them is always the hard part.
So people not going back far enough?
100%.
Okay.
100%. Like and certainly, I look at the athletes in the clubs that come, it's not rocket science, but often their biggest takeaway is how far back the exercise need to be regressed, and the precision and the accuracy in trying to just find the entry point and then pushing forward from there. And a really simple guide to everyone listening is that if you ever have groin pain ever doing your rehab exercise, it's brilliant, because it means you're either doing the wrong thing or you're doing the right thing wrong. So there's no way I should be doing, if I get pain doing my abdominal exercises, it's brilliant because it says my abdominal control is part of the problem. And it also says whatever exercise I've picked or the way I'm coaching it is not helping the problem. It's only poking the bear as you go along. So often in rehabilitation now, we would rarely use analgesics or injections because pain is now our best friend. Pain tells me if I'm doing my exercises well, and the change in pain on a weekly or daily basis is going to be my indication that A, my rehab is effective, and B, I'm reloading them appropriately. So if your pain isn't improving every 48 hours, likelihood is you're missing something either in your assessment or rehab-wise what you're doing.
So from an assessment perspective, what assessments do you use to understand this area and try to piece these pieces of the puzzle together to get a clearer picture?
Yeah, I suppose depending on how irritable they are, you can start at the end or you can start at the beginning. So if you start at the end in terms of their most provoking activities, they'll say that, let's say, running, jumping or change direction are my main provoking activities. So you can look at those large motor strategies, how they're doing it, what are the particular areas that might pathomechanically increase overload in that area or that tissues. You bring that back a half a step and say, right, what are the building blocks for those movements? What's my strength like throughout the compound chain, but also in individual muscle groups, whether that's quads, hamstrings, lateral hip, foot and ankle, etc. My ability to produce force at speed, explosively or plyometrically. And then a step back even further is in, like, what's my motor control like and coordination like. And we're very good at that in the shoulder. The shoulder, we're good at our cuff work, we're good at our scap work. We put it into press-ups and all that kind of stuff. And sometimes we're a little bit less good at it around the hip. So really making sure that we've good cuff control around the hip joint, that we can put that into our compound movements, which would be our squats, our lunges, our single leg RDLs, and then we can start to load them at speed and intensity to generate an adaptation. And so generally speaking, when I'm reviewing athletes, the issues at either end of that spectrum, people tend to do the middle bit quite well, but not breaking down the motor control bit specifically enough, or only looking at the hip and not looking at the trunk and the foot and the ankle, which obviously will have a big influence, or not bringing it far enough in that, well, I'm strong on the bed, I have strong hip abductors, etc., and then not look at them having a huge pelvic drop in mid-stance and running, or a big sway during change direction on the painful side compared to the contralateral side. So I think where people they do the middle bit of strengthening and jumping and explosiveness well, it's either side of that is perhaps where there's more money to be made.
When looking at the trunk, what are you doing to understand more whether that's something that's contributing or something that you could actually do something about?
Yeah, I think when you're looking at abdominal control, a lot of our abdominal tests are bilateral or twin. So we do a plank or we do a hold, okay. But a lot of our groin weakness is unilateral in the obliques and very commonly in the external oblique. So a couple of things you're looking for is the thoracic and rib position. So those that tend to have a more flared or unilaterally flared rib position are often weaker or reduced tone on that side. The second thing you're looking for is when they do load that area, whether it's just lifting their legs or doing a little sit-up, very often they're overactive through their six-pack, through their rectus abdominis, and quite low tone or activity through the external and internal oblique on that side. And then third is you can do a strength test with that, whether it's a manual brake test unilaterally or some form of pallet for other assessment. So you're looking for that base control. Can they get into that rib position? Can they produce force in that position, or do they tend to compensate, most commonly either through the quadratus lumborum around the back, or more commonly again through the rectus abdominis through the front, and then it has quite a small attachment area and often becomes tender there at the pubic tubercle.
And then I suppose maybe going to the other end when you're talking about mid stance and looking at running mechanics, where do you start? I mean, running mechanics is a big topic within itself that we've covered many times with guys in the kind of sprint world. But where do you focus on when things are moving at even at a slower speed, like what I would do? There's lots going on. Where do you focus your attention at that point to try to understand, again, put the bit of a clearer picture where things are going wrong?
Yeah, I think that there's a lot of moving pieces, and again, it's not necessarily that they're going wrong or right. It's more what's efficient and less efficient, or what's contributing to overload or not. So I think even if you break it into two big buckets of stance leg and swing leg, so you can have those guys and girls that get groin pain during stance when they go to push off an acceleration or sidestep, or you can get those guys and girls that get swing leg either when they're kicking or when they go to accelerate and it's the swing leg coming through. But that still doesn't mean that the stance leg is not the driving problem. So we would try, and even if you just broke it into two pictures, picture number one was mid stance, so from behind, what's their foot position like, what's their pelvic drop like, what's their trunk sway like, just to pick three as an example. From the side on, what's their swing leg recovery like, and what's their anterior tilt like. And again, it's not that they're good or bad, but they'll influence how you load one side compared. It's the asymmetry you're nearly more interested in. And the second one then is during toe off. Number one is from behind. Are you able to come up on your first MTP, or are you spilling as you do so? How much are you contralaterally rotating for a lack of drive or stability or coordination through that stance leg? And then from side on, how does it look in terms of your pelvic position and your ability to control that anterior pelvic tilt. So if all you did was look at them at mid-stance and toe off in a freeze frame from behind and from the side, you'll see a lot of big components that perhaps will contribute. And the chicken and the egg here always is, am I moving like that because I'm sore, or is that pattern there? But at least in my experience, where those pattern doesn't change, their symptoms tend to remain, and when you tend to redevelop that pattern, their tolerance improves over time. So I'd be very much a fill in the bucket and see how you go from there.
You mentioned asymmetry there. What value are you putting on a more objective ways to assess asymmetry in different positions, different ways?
Yeah, I think, running, for example, it's a highly variable task. So what's good? I have no idea. It can always be better. It depends on the speed, depends on the sport. I think you're looking for, the majority of groin pain is unilateral. Okay, it can develop by this. So there's a size that's driving the problem. And so when you're talking about asymmetry, you're really talking about which side is driving the problem here. Which side is my drop, my rotation, whatever your metric is. Is it excessive compared to the other side? And your goal then, from an injury rehabilitation point of view, is, can I at least even up the boat on both sides? And then from a performance point of view, obviously, there's a reason that sprinters and high-end athletes work on their mechanics so much, because it's advantageous from a performance point of view. So I think you don't need to look like Usain Bolt. You don't need to be perfect on the treadmill, but you're looking for differences side to side that will explain perhaps some of the motor control and strength deficits that you found already, but also will explain some of the patterns and pattern mechanics that are leading them to become overloaded in the first place.
And I suppose the big question is, because there'll be people out there who are dealing with these kind of situations all the time, with people presenting with these problems, do they have to stop playing their sport, whether it be football or Gaelic or whatever it is? And if not, how would you recommend people managing these issues so they can still do what they do and still do what they paid for and love, but help the problem not make the problem worse?
Yeah, and I had this discussion with a couple of AFL physios recently about, groin pain generally has a relatively low missed games effect in the AFL, but it's a huge burden in terms of reduced training, load ability to perform, etc., etc. So I think the first thing with these athletes is, are you looking to manage the problem or resolve the problem? So, if you have a Champions League final next week, you're definitely looking to manage the problem and play your game and get through it. If you are 2 weeks into the season, are you really going to be able to manage this problem all the way through the season? It's highly unlikely that you are. So I think your first decision here is, am I looking to manage or resolve? The second thing is, really what we're looking for, regardless of whether we're managing or resolving, is every Friday, is their pain improving? Okay? And so if anyone's presenting with groin pain, obviously it's sensible to at least deload them a little bit. And deload them may not be necessarily reducing volume or intensity. It might just be a reduction in the most provoking activities. So small-sided games are really hard on the groin. Shuttle runs for conditioning are very hard on the groin. So you might just take away some of those more provoking activities. But what you're trying to do is deload them to a level where they're no longer getting sorer, and then concurrently trying to address the factors of why they become sore in the first place. So if you can find the right level of load, whatever the hell that is, and are concurrently addressing the biomechanics and the functional deficits that are leading to that, you should then see every Friday that their groin is feeling better than the previous Friday. But if you can't get into a weekly rhythm where their symptoms are improving over time, obviously, if it's only 3 weeks left in the system in the season, doesn't really matter. Just work your way through. But if you're at Christmas and the season's going to the end of May, there's no way you're going to last if you're not able to find a balancing act between that. And there are those that are just so sore where their training load has dropped to a level that's negligible, and they're probably better off just pulling the plug, wipe the hard drive and rebuilding back up again.
Would there be any particular markers that you would look to enable us to reintroduce that load if they are just play on the Saturday and almost doing the minimal throughout the week?
Yeah, I think your pain provocation tests are a key indicator of your groin is always right. So how you feel getting out of bed in the morning more or less tells you how things are going, whether that's your activities of daily living or more specifically your pain provocation test, which most commonly would be a crossover test, which is hip flexion and Thomas test position, any one of the squeeze tests at different knee flexion angles, or maybe a crunch test or some kind of abdominal loading test. So really we're looking for those tests to track either improve pain or same pain with improved force on a weekly basis. And then concurrently, that's highly unlikely to happen if your functional markers, that could be your hip range of motion, your motor control, your strength, etc., if they're not improving on a concurrent basis. But certainly you would want to make a clinical decision on, right, we're not going to reintroduce X or Y or Z until his squeeze at pain-free is at 45 is completely pain-free, until his long lever squeeze is completely pain-free. Otherwise, you go halfway up the mountain and you roll back down again. So I think you're looking to put in some hard and fast thresholds, and you want them to maintain that symptom-free for at least 4 or 5, maybe up 4 or 5 days, up to a week, before you can be confident that symptoms are stabilising and you can push on from there.
I know you said that if you're going to go look for something, you're potentially going to find it, or probably going to find it. But is there anything that you would do or recommend other people do on a day-to-day or week-to-week basis to try to get ahead of this, so we're catching it beforehand? And if so, what would it be?
Yeah, I think there's 2 cohorts that are at high risk. Those that had groin pain the previous season are much higher risk, and young athletes coming into your senior squad. So they're the 2 groups. Certainly, if I had to streamline what I was doing, that's where I would put my energy. If I had only 2 tests I could do, number 1 would be a long lever squeeze test. Is quite sensitive, and often they'll be a bit sore on that before they start reporting pain during games. So if you are starting to drop off, and that might be a flag to you that you need to do a more comprehensive assessment and really dig into why that's happening. And the second one would be a loss of hip internal rotation passively at 90 degrees of hip flexion. Now, there's a whole host of reasons in terms of motor control and coordination about why you might lose that. But if you start losing your hip internal rotation, that's going to greatly influence the stress and strain that goes through the superior pubic ramus, the symphysis pubis, and the adductor muscles as well in particular. So any loss of hip internal rotation from your normal would be they often will be pain-free that will often have dropped off before they develop symptoms. So that would be just a quick screen, is everything good, and away we go. And then the second would be the long lever squeeze and flagging that. And the reality is that most groin pain is really easy to manage when the players tell you early that they're beginning to feel a niggle. The problem is none of them do, because it is only a niggle, and they're able to play on, and they don't want to they want to train, and they don't want to drop off, and etc. etc. So, you know, if your playing group has trust in you that, look, if you feel anything in this area, you can keep training away, but let us know so we can intervene and get stuck into it. I would say that would take away almost 50% of the issues before they even got going.
What would you consider a drop-off and a potential flag on that long lever squeeze?
Yeah, pain would be the marker for me.
Okay.
Like, depending on your level of fatigue, depending on what you're doing, etc. A lot of teams and franchises would have other, neuromuscular screening, whether that's jump testing, etc., to look for freshness over time. So there's lots of reasons your numbers might drop off. But if I'm developing any kind of sensitivity during that would be a hot flag for me to be more robust in my assessment and find what's driving that.
And then more generally, in terms of exercise prescription and I suppose strength and conditioning perspective, what would you do, or what do you recommend other people do to get ahead of this even further, to actually incorporate it within their strength and power programming to hopefully enable this not to happen?
Yeah, I think there's probably 3 big buckets. Number 1 is, being fairly meticulous on your coordination during your strength exercises. We've all seen people squat, and I'm talking about field athletes here. We've all seen people squat, lunge, deadlift in a lot of anterior pelvic tilt. The 2 real reasons for that, it's not that that's bad, but you're probably not getting the mechanical stimulus where you want it. So rather than feeling it through the quads and the gluteals, you'll feel it elsewhere. But also that's going to influence how early you impinge and the load through your hip and your pubic region. I would do a lot of unilateral work. I think there's a whole lot of way for our field athletes. Like, so many of their deficits are unilateral. So many of the ways of hiding are covered in bilateral exercises. So That'd be my personal preference. And then being really, while a lot of groin programs tend to focus on adductor strength, the most common deficits I find are in the lateral hip muscles and in the obliques unilaterally. So a lot of unilateral rotational work, cable work, rather than plank exercise are a waste of time. You want as much of your abdominal work to be rotational, either through rotation or anti-rotation, and make sure that you're feeling in the obliques when you're doing it, because that's most commonly what I don't see happening.
Amazing, perfect. One of the final questions, I think we'll spend a bit of time here, and this is on my reflections from our previous chat on this. And like I said right at the start, it seems a long time ago, and it is a long time ago, in 5 years. In that time between then 2020, maybe it was 2019, what have you changed your mind on in this particular area? What are you doing differently now than you were back then?
Of course, I'm stubborn, so I never change my mind. But I think if you look at the evolution of practice, I'm far more acutely aware of my inability to be specific about where the pain is coming from, and that's fine. I feel I have seen enough, or made enough. I wouldn't call them mistakes, but seen enough to be able to flag the guys and girls that are that need alternative opinions on this. They just look different when you've seen lots of them, and I think the evolution of my practice has really been around not only probably my foot and ankle work and how important that is to how you're able to control the hip, doing a lot more around, especially with your more bigger athletes, so let's say rugby, AFL, NFL in particular, how important shoulder mobility and control is on thorax function, and then as consequentially through onto the groin. And while I've always had a firm interest in running mechanics, starting to layer more analysis on that, especially in the horizontal mechanics. So we would have always looked at instrumented treadmill and treadmill analysis and picked up the big things, but looking as much at acceleration now, with some new equipment, looking at horizontal force production, asymmetries between sides, and really targeting that more specifically. Going back to, you see what you look for and you look for what you know, so the more assessment that you have with you, and that even goes back to the availability of ultrasound. So like we would ultrasound all our groins for the posterior wall, and the number where you see weakness that's probably always been there and has nothing to do with it is phenomenal. So they're probably the key bit. Don't get too, and that's probably had the knock-on effect. If I can't be very specific, if I can't be very certain about where the pain is coming from, or at least certain that me and you will agree where the pain is coming from, then it means rehab-wise I need to be really, really robust, and my rehab program needs to be very, very flexible to what that athlete needs rather than to where I think the pain is coming from. And that's probably become even more entrenched over the past couple of years.
When you mentioned the foot and ankle, a bit more of a focus there. What does that look like? When you say focus there, what do you mean?
Yeah, I think, while you will always find deficits, around the hip and at the trunk, if you're not concurrently addressing anything around the foot and ankle, it's like putting water in a bucket with a hole in it. And so I've had those athletes where, look really robust strength-wise, and the lateral hip mechanics were good. You look at them 2 or 3 weeks later and they've lost it. You're thinking, people don't decondition that quickly. What has happened here? So not only on foot and ankle mobility, I suppose we're preoccupied with ankle dorsiflexion, knee to the wall, but like foot mobility is far more complex than that in terms of your first MTP and especially your midfoot and forefoot mobility. But being able to, a bit like we talked about the hip, being able to isolate the specific components of the foot, whether that's the intrinsics, the flexor hallux, the peroneals, the tib post, and then bring them into functional movements. I think the ability to identify those and get carryover quicker has certainly made my robustness improve a lot in terms of my hip control and strength.
And one of my final questions, because you have so many externals, and you did in Ireland as well, so many external athletes coming to you, you speak to the people who are looking after them from a rehab perspective. What trends are you seeing, or how have trends developed over the last 5 years in the practitioners that are actually bringing athletes to you? And how has their practice changed? And from when you talk about their particular athletes, are we focusing on? Back then, 5 years ago, we were focusing a lot on this, but now it seems to have trended towards this, this, and this. I'm just interested to get a bit of an idea there, if you've got any insight.
Yeah, I think it's those changes are very regional, so certain areas, certain countries have evolved more than others. I think there's a far better appreciation that not all groin problems are driven or solved by adductor strength, that adductor strength is really important. But if adductor strengthening is the only component you have in your prevention or rehab, you're probably going to sell yourself very short. I think the ability of clinicians to analyse movement has greatly evolved. That's partly to do with the proliferation of force plates and their understanding of that. Again, the pendulum is probably swinging too far in that regard, in that, I wouldn't say an over-analysis, but an over-interpretation of the force plate analysis, that if the forces are good, whatever the hell that means, that all is well in the world, is a second part. And then thirdly, I think their understanding of human movement is a skill, and like any skill, you can create a good learning environment or a poor learning environment. And what you can see a lot with the motor redevelopment work is how people are really getting good at creating drills and exercises that allow patterns to emerge. So rather than tell it used to be you need to lift your knees more, or you need to stop swaying, or you need to brace, or whatever else. And you can see that the profession as a whole is really evolving in terms of understanding motor learning, in terms of understanding rehab-wise, what vocabulary do I need to give them for those patterns to emerge, but then concurrently how the more that I'm talking, the worse that my drills are, and the need to that to improve. So the biomechanics side is probably still a little bit limited off the back of we haven't seen the cost-effective spread of technology there the way that we have in force plates. So that's probably 5 years behind, but it'll come as well at all. The marker-ness technology has a lot of potential. No one's really doing it that well or doing it better than the marker-based technology at the minute, but everyone has a camera phone, and certainly people are recognising a lot of the pathomechanics, and even if it's not objective, but even able to subjectively identify them and communicate them to their athlete and try and address them. That's been a huge evolution over the past couple of years.
Amazing. Right, I know you're a very busy man, so I'm glad we've got...
Nearly as busy as you, nearly.
Yeah, I don't know about that. It's busy as each other. Everyone makes themselves busy, and I'm the worst at it. So if there's a bit of free time, I'll fill it with making myself busy with something. So I'm pleased we've got through the main points that I wanted to cover. If anyone wants to dive into some of your work or follow what you've got going on, where's the best place, Enda?
Yeah, I'm passively involved in social media, or at least as passively as I can, on Instagram and Twitter. So Enda_King, or at Enda_King, and then I try periodically to update my website, which is enda-king.com, where all the research papers were involved in. But I would encourage people to follow any of my colleagues in Aspetar. Certainly there's a lot of more research coming out now in the very short-term future, and they're all developing on some really nice programs and sharing content. So I'd encourage some of them as well.
Amazing. Thank you very much. Right, I will let you go, but look forward to seeing you in June. Excited to have you there for the pre-conference and the main conference. And you are speaking first thing. In the middle you've got Tyler Lesher, and then you're bookending him. But yeah, excited to have you there, mate. And thank you for coming on. I appreciate your time as always.
Not at all. I'm very excited for Rob. As I said, I'm more excited to go and listen to who else is presenting. It's a cracking lineup, and an excellent location. So yeah, very much looking forward to it.
Thanks, mate. Catch you soon.
See you soon.
See you soon.
Bye.